Um, Thanks, Tiffany. So welcome, everybody. So glad you're all able to join us. Good morning, good afternoon, good evening, depending on where you are in the world. My name's Sohail Sood. I'm a pediatrician at the University of California, San Francisco. And as part of our Global Child Health Lecture Series, it's my pleasure to welcome Dr. Robin Goldman to speak to us this morning. She is trained in caring both for children and adults, full spectrum, in hospital settings, and works at a number of hospitals in the San Francisco Bay Area as one of her many duties. She's also works quite extensively with the Health Equity Action and Leadership Fellowship, known as the HEAL Fellowship through UCSF, which takes her to many parts of the world. And correct me if I'm wrong, but I believe her role there is to focus on education and strategic initiatives. And maybe with that, I will turn it over to Robin to share a little bit more about herself, her work, and importantly, an interesting exercise in thinking through how we think through the patient in front of us. Maybe I'll leave it at that. Thanks, Robin.
Yeah, thank you so much, Sohail, and thank you to everyone for joining. I know that for some people it's early in the morning, and maybe for some it is later in the evening. So I really appreciate you being here. And yeah, as Sohail said, I do a mix of clinical things along with some global health equity education work and program evaluation. And so really excited to talk to you all about some frameworks and sort of thinking I did when I was in a global health fellowship now 8 years ago. And hopefully this is useful for everyone in their practice, wherever you are. And I guess and I'll tell more of my story along the way and talk about a little bit about HEAL specifically at the end. But with that, will share my screen. So I think most people were able to introduce themselves in the chat, and I will be using, I encourage people to speak in answer to any sort of prompts or questions, but also feel free to use the chat. And then, as I mentioned to a few people earlier, there'll be an exercise where it's helpful if you can write things down. So if you have a scrap piece of paper and a pen or pencil, that will be helpful. And so with that, I'm going to be talking about structural analysis today. So really thinking about trying to understand the patient in front of you and their story. And I want to start off by recognizing the land that we're on. For those of you in the Bay Area, we're on Ramaytush Ohlone land. I'm actually out on the East Coast today. So I am on Piscataway and Anacostan land. And then my talk really centers on Haiti and the ancestral people there, the Taino, who unfortunately were totally devastated by colonialization, but really honoring the ancestral stewards of our land and their descendants who continue to steward this land, and realize that I am a guest on their land. And so these are quick objectives for the talk. We're going to go through some definitions and frameworks in the beginning, and then practice structural analysis and talk a little bit more about the uses of structural analysis in your work and practice. And then I'll provide an overview of HEAL at the end. So I'm just wondering if people can put in the chat what made them interested in global health and whatever that means to you. I know this is a global health series, and it seems like many of you are in tracks or on electives for global health But I think I've realized that what global health is means a little bit of a different thing to different people. So thanks, Teresa, for starting us off. Looking at health disparities sort of on the global scale. Okay, thinking about access to healthcare. Thanks, Alexa. Get a couple other people. Thank you, Edna. Yeah, the upstream factors introducing health, influencing health disparities. That's great. Okay, well, feel free to continue putting things in the chat. And so I love that we're all interconnected and intertwined, and we have a shared responsibility for each other. So I think to start off, I wanted to define global health because it means different things to different people. And I think in searching for a definition of global health, it's actually pretty hard to find. And this is what I chose. This is based on the work of Paul Farmer and some of his colleagues. But really that global health remains a collection of problems rather than a discipline, but they all center around a quest for equity, which is what I heard in some of the things that people said of really like thinking about how do we think about disparities in access to care. And so then if we combine that to global health equity, that field is a multidisciplinary approach. And I think taking the words that I've bolded, really thinking about how global health incorporates the very like micro level things all the way to very macro level things, depending on like what axis you're looking at. And so local to international, molecular to social, and really this idea that global health equity finds a biosocial approach to what are biosocial problems. And so I think a different way of looking at things than what we traditionally see in I will speak for myself in medical education, but I think from talking to other people also in many healthcare professions, such as nursing or physical therapy or pharmacy, there is really a focus on that micro or that biological, even though we realize the problems that our patients are facing are much more biosocial. And so that was thinking about sort of how do we get to equity? And so what is inequity? And this is kind of a fill in the blank of whatever axis of inequity you want to think about. So whether that be race, gender, country of origin, or ability level, or many other things. But inequity is really caused by a system of structuring opportunity and assigning value based on whatever access that is. And what that does is it unfairly disadvantages some individuals and community, unfairly advantages others and individuals or communities. And I think the thing that that often gets left out when we talk about inequity is that this system of structuring opportunity and assigning value in a certain way to certain people really takes the strength of our whole society and wastes our human resources. So we are all affected, even those that are unfairly advantaged. We are all affected by the inequity in our society. And so this definition is by a woman named Mara Jones, who I'll refer to a fair amount in this talk. But this has felt to be one of the more all-encompassing definitions to me that I think really gets at some of this societal and structural level effects of the inequities in our society. And so I'm going to talk about a few. So we're going to go into an example of structural analysis later in the talk. And I'm going to talk about a couple of frameworks that have really helped me think through my ways of analyzing the structures in our society. And one of them is the socio-ecological model. People who have spent time studying public health have probably seen this. It's this idea that like every individual is affected by so many layers of things around them. And so you have your own sort of personal beliefs, knowledge, and thoughts, and those are affected by your relationships with other individuals. Those relationships are affected by the institutions you exist in, whether that's schools, work, religious institutions. And those institutions are affected by the community. And then all of our communities are affected by policies and structures, both current ones as well as historical ones. And this is another model that is a little bit more specific to health. But you can see that the similarity with the socio-ecological model is that the surrounding this person in the middle are institutional and institutions and systems, as well as our policies. This particular picture is focused on race, but again, this could be applied to anything. In this idea of equity, and then we get to factors that like directly affect the individual and socioeconomic factors. So we see some factors that span the different levels that I showed previously in the socioeconomic model, but just another way to think of like, what are all the things that influence someone's health? And what I like to point out in this particular model is that healthcare, sort of if you think of like the weight of things that affect health outcomes, really is a small portion of what affects people's health at 20%. And so while healthcare is really important and things like antibiotics save lives and oral rehydration solution definitely saves lives, there are so many other things that affect someone's health status or health outcome. And so I'm going to start with a case that I saw when I was in Haiti. I guess as a little background, back in 2014, I did a global health fellowship and worked in rural Haiti with Partners in Health, and sort of was, part of my global health journey, and really where I started thinking about structural analysis. And so this 2-year-old presents, her mother brings her in, and the mom says, she's fussy, seems like she doesn't feel well, and has been having diarrhea. Does anyone have any questions they'd want to ask the mom or thoughts about what might be going on?
I would definitely want to know the basics, like medical history, and then just expand on the story. Like, how long has this been going on? Has it become worse? What have you tried to help? Things of that nature.
Yeah. So medical history, no real medical history, full term vaginal delivery, hasn't really had to interact with the healthcare system since, occasionally would get a cold, but nothing that they've needed to seek medical attention for. Sometimes nurses come around to where they live and give vaccinations. And that's really been the only interaction with the healthcare system. And then, yeah, in terms of symptoms, the diarrhea has been going on for a while. It's been more than a few weeks. No one else has had diarrhea. Yeah, no fevers. They live in Haiti, in rural Haiti, in a kind of farming community outside about an hour walk from the capital of the region. And multiple loose stools a day, but sort of not like all the time. And again, it's been going on for a few more than 3 weeks.
Couple more questions regarding
Yeah.
like hydration status, urine output. How are they POing?
Yeah, great. So the on triage, your vital signs are okay. The child doesn't look well, and actually looks pretty kind of puffy. So it has edema in her feet and her calves, but also mucous membranes are dry. So anyone, I guess, moving to thoughts of what this might be?
Yeah, I think that the first, well, I guess we're trying to figure out if this is like an acute presentation of diarrhea, like a gastroenteritis, or if it's a chronic malnutrition condition.
Yeah, I think that's a great place to start from. Yeah, and I think this is what we were thinking about. And then for me, given sort of the puffiness and lower extremity edema, as well as this history that this has been going on for weeks, malnutrition sort of rose on the differential, and then talking with the mom, there had been trouble with food access previously, and so this child was diagnosed with malnutrition, exactly, Fritz, and so thinking about, sorry, I'm having Zoom trouble. So, and this is not her, but an example. So diagnosed with malnutrition, and I think thinking through, if people can just throw out there what we know that malnutrition, the most proximate cause of malnutrition is not having enough food. And what factors can you all think of that may lead to that for a family? And you can take it from a context you've worked in, or you can try to imagine it in this context in rural Haiti. Yeah. Yeah, thanks, Hannah. So I'll probably highlight financial, like, quality of food available to them. So both quality and availability, access to clean water. Yeah, those are great. And sort of to point out, I think, as many of you know, the treatment of malnutrition, once someone presents to the healthcare system with malnutrition, is tends to be straightforward, and in many settings doesn't even can be managed locally by community health workers and nurses, and has become, I think, pretty protocolized. And so you know, the solution usually is to get people nutrition, and some kids with severe malnutrition need some monitoring or may need antibiotics and other treatments, but many children, as you start giving them appropriate nourishment, start to do better relatively quickly. And I think on the treatment level, in some ways, we've have this figured out. And at the same time, many healthcare workers see this day in and day out. According to UNICEF, malnutrition is the leading cause of under 5 mortality in Haiti. And so clearly, while we know how to treat this, it still contributes significantly to the health disparities we see in Haiti. And then giving voice to things that people have written in the chat. So political stability, very much an issue right now in Haiti, and can affect food access for sure. And then comorbidities, agree, like HIV can really also affect patients' ability to stay nourished. So thank you guys all for your suggestions and thoughts. I'm going to go through sort of what I came up with in talking not only to this family, but to other families in terms of this. You know, so you have this child in front of you, that's the patient in front of you, and you know that they are having difficulty getting food. And I'll actually start out with things that I don't think have been brought up in the chat yet. But this was the first thing that that I really got after I was talking to a few members of the community, not actually relatives of this kid, but from the same community. Because I was actually out, like, at a sort of a malnutrition tent that was brought into the community, so not people coming to the hospital. But so the difficulty getting food, and then people talked a lot about crop yield, and so this their crops getting kind of washed out by the rains that over the past few years. The number of heavy rains had really increased, and they were seeing things get washed out more. And so then, like, crops for an entire season would be ruined. They talked about the cycle that they had gotten into, that when the crops were ruined, what a lot of people would do is actually cut down trees to to then make charcoal and sell that, because that's what they needed to make an income, because they didn't have any crops to sell or to barter with. But that then further led to, and I apologize for the limitations of a 2D screen, but that further led to like decreased trees and vegetation, which then led to more poor soil, so things weren't growing well, but also increased washout events. If I then take this a step further, all over the world, we've been seeing increased climate events as a result of climate change, with more for Haiti in particular, more hurricanes going through the region. So in addition to kind of heavier rains on a smaller scale than hurricanes that are really causing a lot of devastation. So that's kind of one subset of analysis. And then I think getting to some things that get to some things you all brought up. So, most of the people in these communities are farmers. And so this decreased crop yield decreased their income. And the charcoal maybe helped it. So all influencing how much money they have to buy food, as well as like the food they grow themselves. And then if you think about it, there are not a lot of job opportunities other than farming in this particular community. And sort of historically, Haitians in more rural areas and Haitians who are not of mixed descent, so kind of mixed French colonizers and slaves, but the darker skinned, more rural populations have had decreased access to education. Part of that is because there are fees to go to school, and people don't have a lot of money. There are also language barriers. School is still in French in Haiti, even though something like 90 to 95% of the population speaks Haitian Creole and does not speak French. So another barrier for people to get into the formal sector through education, or to be able to get a job. And then a lot of this comes down to how much money the government has. I didn't write political stability, but that is definitely a factor in here, as well as racism. And then some of you may have heard, there was a recent big New York Times story, but if you go back to Haitian independence, so Haiti, I think, celebrates that it was the first colony to get its independence, and really the only successful slave revolt ever. But that led to embargoes and this debt to France that not only the government was paying back for hundreds of years, but also really decreased individual wealth as well. And yeah, thank you, Teresa, for sending that. There are a few really interesting articles. If you all have time, it was a really great investigation by the New York Times. But so, I mean, a lot of things going back many generations, and then there's stuff, the racism and the language stuff goes back many generations, but is still present today. And then go a little bit further. So you can keep going and or one can keep going, but I think another thing, and some of this I got through talking to individual patients, some of this I got from talking to my Haitian colleagues, and some of this I got through my own reading. So this map is something that I developed over time, and I like kind of add to it as I think of things. But agricultural policies, and so not only policies within Haiti, but actually US agricultural policies have really affected Haitian farmers. And so the US making certain things like white rice really cheap and importing them into Haiti kind of devastated the Haitian rice farmers. But I think the US has used the government instability in Haiti as a way to kind of push through its own agenda and policies. And then we have some international issues that I think we've been hearing a lot more about with the COVID pandemic, but patents have really made it hard for low-income countries to get access to vaccines, treatments. I think in the case of malnutrition, sort of protein nutritional supplements have been blocked by patents. And so I think all to say this goes into the, a really complex web of things that have affected this child that I saw. And again, I didn't do all of this in real time when I was seeing this patient, but it was sort of like as I, talked to more people and got more information. And I think for me personally, really helps me step away from one putting things on the patient. So I think there's a tendency within the healthcare system, particularly when we feel helpless and frustrated about how unfair things are, there is a tendency to put some of that on the patient. So part of what this does for me is to help check that. But it also helps me to see like, where are the places to intervene? And, they don't all have to go down to like government stability. I don't know the fix for government instability in Haiti, and I don't think very many people know, and that is really up to the Haitian people. But you could imagine like local agricultural interventions or something around job opportunities may feel much more approachable in a way that you may be able to partner with people who have expertise in those areas to help a larger subset of patients than the one that you're treating. And so from that, I'm just going to talk a little bit about, again, just giving you guys some frameworks of ways to think about things, but the levels of various axes of inequity. And so the sort of most macro level is this institutionalized level, so differential access to goods, services, and opportunities, which was a lot of what my diagram was about. And so these really operate on a societal and structural level, and are the things that create our societal norms. There are the interpersonal levels, so the assumptions that one makes about other people, and this is about their abilities, their motives, and their intents, and is really what leads to prejudice or discrimination. And these can be intentional or unintentional. And then there's internalized, and I think, for example, internalized racism or internalized gender bias, of this acceptance of the messages you get from the institutionalized and interpersonal levels about your own ability or worth. And so I'm going to pause. I've done a lot of talking, but I would love for people to just think about a patient you've seen or someone in your community, and start to do a map based on either what you know about the community they're in or the stories you've heard from that patient. And this can, either be a patient that was really sick or a patient who maybe presents over and over again with issues. And so let's spend about 5 minutes. So I'll say until 45 of whatever hour you're on, and actually try to start drawing things out, and then we'll come back to the group and share. And feel free to speak up or put something in the chat if there are any questions about this.
Hi, Robin. There's a question in the chat, just wondering if you can summarize again a little bit on the task that you're asking of everybody.
Yeah. So just like I did with the malnourished patient that I saw, think of someone with a health problem, either that you've seen yourself or that exists in your community. I think depending on, I know everyone has different roles here. And then start asking why. So start asking, like, why did they present with like that, and see how far you can get or how many influences or forces you can map out. Does that help? Yeah, exactly. And I think going from risk factors even to, like, if you can think about it, history or policies in society that affected the presentation as well. All right, we'll do one more minute. So wrap up your brainstorming. All right, and I will bring everyone back. Go back to sharing my screen. Actually, I'm not going to share. How was that for people? Like, how did that feel? Or yeah, like, what's your impression after you tried to do a little of structural analysis and map things out? Okello?
Yeah. So basically, I've tried to. It's like you're looking at sort of a mental. I had the mental image of the patient I had, and I tried to rule out certain things and give the reasons as to why they were. One, they presented with failure to thrive, and a 6-year-old male, and was had low weight for age, and looked wasted. But also, interesting enough, they had access to food. So on further examination or interrogation, there was no known chronic illness. However, they were feeling hungry and also frequent urination, which led me to suspect this patient could also be having diabetes, undiagnosed diabetes. So what happened is that when they did the HIV test, it was negative, and there were no overt signs of malnutrition. Okay, there was no edema, but of course was malnourished and wasted. And on doing the random blood sugar, got 26 millimoles per liter, around 468 milligrams per deciliter. And this led me to a conclusion of a type 1 diabetes, which was not diagnosed. But that explained the child's appearance. And on starting the child on the medication insulin, the child started improving and gaining weight. Thank you.
Thank you. Type 1 diabetes is, that I think brings up a lot for me, and I'm gonna keep asking you questions. But is this a child that you followed since the diagnosis? Have you seen them again?
Yes, they are even doing well in class, and they are attending their clinics so well. So I'm following this child. Interesting enough, was a child I clocked during my examination, and indeed it was their first time to be diagnosed. So I would say, as I was being examined, I ended up diagnosing the child.
I think when I think of type 1 diabetes, and every context is different, but that can be a very challenging disease to manage. How has the family done with being able to obtain and manage insulin for this kid?
So interesting enough is that the mother actually is a nurse, the mother was a nurse, she's still a nurse anyway. So she has access to insulin since the child was put on the register for diabetic children, and given days when to come and when to. So when she can easily access medication, she can even easily access corrective measures in case the child ends up with the hyperglycemia. As children, there are also challenges. The child, first of all, one of the challenges, I met her like a week ago, and I was asking her about the child, and he was saying that the child feels is a bit fed up of the needles, the injections he's getting.
Yeah.
So those are some of the things that makes him want to start dodging coming to the clinic. Yeah.
And what in your context, would everyone have access to insulin, or is that just something because this woman works in healthcare?
That's true. I think it's because she has easy access to it, because one, she can easily consult doctors since she's near them, and two, she works in the hospital environment, so it's easy. Even if it has run out of stock, she could easily maybe go to the private wing and ask for a dose or something to come and give. Whereas another person from outside who is not familiar with the system, definitely, if they do not have money to buy the insulin out in the pharmacies, it will be a bit hard to them. So I've seen some patients for here in the hospital. What happens is that, at least for children in children's ward, children with diabetes, some of them are being assisted by some NGOs who come and sponsor some vital medications like insulin, and then even they give out free glucometers and prickers. Whereas for the adults, it's really hard. For the adults, it's a bit hard, because if you do not have money, you may not achieve the medication goal that you are expected to, and also you may fail to buy the monitoring tools to use. So, to be honest enough, I think this child is doing well monitored, because the mother somehow is related or is familiar with the health sector, and also familiar with the providers of the service.
Yeah. Thank you. And so if I think about how I would map that, so if you took, a child with type 1 diabetes in your setting, it sounds like some of the things, so one of the things that influences how well they do with the type 1 diabetes is access to insulin, as well as what you brought up of access to food. And then access to insulin sounds like it depends both on money, as well as sort of kind of knowledge of the healthcare system and being able to navigate it, as well as an ability to easily access a pharmacy or somewhere where insulin is available. And I think you brought up some ways that your community and your society has mitigated this is that, there are certain organizations that, because cost is a barrier to some patients, and certain organizations have decided to provide insulin free of charge to certain families, knowing that when you have type 1 diabetes, without your insulin, you will get sick and potentially die if you don't have access. And so you actually really nicely presented the ways that people have navigated some of the structural barriers. And then if we took it a little bit further, I think, there's access to pharmacies and healthcare facilities, and you could think about what is the transportation infrastructure like? How do we make it easier for people to get to these places? And in terms of financial, you can think about what things, I think, like I brought up in Haiti, people's access to education and access to jobs may influence how much money they have, but also like who gets linked up with these NGOs that are providing the free insulin. Are there certain patients that are more likely because, you know, the NGO is located in a particular neighborhood, or they send out workers to particular communities, and that means other communities don't get those resources. And so you can start to think about both how have we intervened on these levels of structural violence that affect people, and how do we keep going back and thinking about the other things that influence, and thinking about, are there other ways to intervene? So thank you for that example. I am going to, let's see, go back to my slides. I guess actually, if maybe people can just put in the chat, I think different people have different reactions to sort of mapping out these forces, but how did it make you feel? And sort of if people can just put, you know, 1 or 2 words about, like, it made me feel horrible, it made me feel empowered, or any range there in between, of how actually doing one of these maps made you feel. Okay, so some clarity. Yeah, Matt, I think that's very much what I identify with, is like feeling like a level of understanding that I don't usually have while I'm seeing people clinically. Yeah, thanks. Thanks, Hannah. And I think, Hannah, to your point, like getting to the whys, some of that actually does involve like more conversations to learn about what's affecting patients. And then, yeah, Jason, it can feel, I guess you said constraining. I think it can feel overwhelming sometimes. There's so much, and like what is possible. I think in the interest of time, I'm gonna there's a video that I think again by Kamara Jones that reiterates or says in a different way some of the stuff we've been talking about, and I'm just gonna put it in the chat. And then, yeah, thank you, Alexa, for voicing that. It's a little bit overwhelming and like impactful, or what, you know, what can we do, and where can we have impact? So that YouTube link I posted is like a less than like a 5-minute video that just talks again about like how do we start addressing some of the factors beyond just treating disease and some of these systemic factors, and is like a cute, nice model of ways to think about it. And I will like people work on that on their own time, or listen to it in their own time. But I think for those of you who this feels overwhelming, and I personally have had the thought of like, you know, I went to school and trained to do clinical work. And so, you know, some of the things like agriculture feel very outside of my wheelhouse, or how to change educational policy to make it so that more people can go to school and have better job opportunities, or even how to start up a like microfinancing system in a community. Those feel very outside of my wheelhouse as someone who was trained clinically as a physician. And what the evidence shows, so if you look at research that's been done around clinicians specifically, so people who interact directly, who work in the healthcare sector and interact directly with potential either patients or potential patients. What they found is that talking to people about the societal and structural factors and listening to their stories about all of the forces that have influenced their life and their health actually leads to increased empathy with patients, and that patients themselves report improved relationships with their healthcare providers when the social determinants they face are asked about and identified, even if the provider can't do anything about any of them. And I think all of us know that having good relationships with your patients is so important in terms of moving their health forward. And then I'll add that, like, you can't change anything, or you can't even ask somebody else to help you change something or to work on something if you don't identify it. And so really, I think in the past, I had the tendency to feel like, oh, there's so much in this world that, like, I can't fix. And so it's easier not to talk about it. But what I've learned over time is that your patients, like, want to be asked about it if they can't fix it. And sometimes talking about it, like, things will come to mind that you actually can do something, or that you know someone that can do something, or you can think of an organization that can do something. But if you never ask, you won't identify that. And so really asking your patient their story, and this can be in 5-minute intervals. It doesn't all have to be at once, because I know that some people only have 10 minutes to see a patient. Challenge your own implicit biases, and then think about, are there big or small systems changes? And then I'd like to add that as people who work within the healthcare sector, you have a level of credibility that your patient, like, when talking to NGOs or talking to other organizations in your community or talking to government, you have a level of credibility that your patients don't have. And so sometimes you need to be the one to relay their voice. And so this is not to say to speak for others, but to use the power that you have in a way that helps your patients. And so I'd like to talk a little bit about a program in Haiti that is addressing some of these factors that affect malnutrition, and it is by far not everything that I put out in that slide, but it is a start. And so, as I mentioned, I was working for Zami La Santé, which is Partners in Health in Haiti, and I think they became decently well known across the US at some point, mostly probably because Tracy Kidder wrote a book. But someone who actually did do work in agriculture at some point just reached out to Partners in Health and said that they wanted to do work to try to help address some of the agricultural difficulties that people were having in Haiti. And so what started as, like, I think one conversation between two people has blossomed into, like, this really wonderful program called Zami Agricole. And Zami Agricole means partners in agriculture. And it is a program that started out actually as I think the first thing they did is like, I guess it's called micro lending, but of goats. So they would loan a goat to a Haitian. The goat, there are goats kind of everywhere, or like around, but so lend a particular goat to a patient, that goat would go on to have babies at some point, and they would like repay the loan of the goat with the babies of their goat. And so it was this process of like goat loaning that that helped to start some wealth within families in that community. And with this idea of you kind of pay it back and pay it forward. And then the other thing that they started to do was to think about the nutritional supplements that we use for malnourished patients. And these are very expensive generally on the world scale. There's a patent that the European company who developed them has. And what they ended up doing is actually, but the recipe is like, it's not that complicated, but there's a patent protecting the actual recipe. And now I'm only remembering the Haitian name and not the English name for
Is it plumpy nut?
Plumpy nut, yes, thank you. In Haiti is Nurimamba, but yeah, so patents protecting the recipe for plumpy nut. And so what they ended up doing is actually negotiating with the makers of plumpy nut to share the recipe with a promise that they wouldn't sell any of the plumpy nut equivalents that they made, and wouldn't share it per their preference. And so this organization, in addition to starting to work with farmers, also made a facility that made plumpy nuts, and the Haitian Creole is Nurimamba, from peanuts grown in Haiti. And so ended up hiring workers both to grow the peanuts as well as Haitian workers to grow the peanuts, as well as to make the plumpy nut or the supplement. And so created jobs, but also created free nutritional supplements for the community, and it feeds into the PIH system. And so again, this is just one example, and none of that was done by the clinicians that were seeing these patients, but did come from talking about it, and then the relationships that developed from there. And I think, is a way that people have gotten around patent laws, as well as creating job opportunities and teaching sustainable agriculture techniques to members of the community. And so that is just one of my favorite stories about how to potentially intervene on some of these structural forces. And so I think this is a very short summary, but as you think about how to fight against inequity, first is naming it, then asking how is inequity operating here, and then is acting to create change. If before I think I have a few minutes to talk about HEAL, but here are some resources in case you're interested, but I think always read about the history of where you're going to work if you're not from there. And then structuralcompetency.org has lots of resources, as well as the New England Journal of Medicine has case studies in social medicine that are really interesting and bring up a few of these different types of analyses. And so I'm going to briefly talk about HEAL for those of you who are, and I'm sorry, this doesn't apply to everyone, but for those of you who are based in the US and interested in further work in global health equity after your residency training, the Health Equity Action and Leadership Initiative is a bidirectional interdisciplinary global health fellowship with a mission of training and transforming frontline health professionals through building a community dedicated to serving the underserved really with a vision of working towards equity for even the most vulnerable populations. And the fellowship is grounded in values of humility, immersion, seeing the work as everywhere and as incremental, and solidarity, responding to structural violence, and then really the importance of creating community. We currently work in Navajo Nation, a few underserved areas in California, along with a number of countries internationally. I think our model is pretty unique, but the people who participate in this fellowship are both people who do not live in underserved or very marginalized areas, but are interested in working there, as well as people who actually live in these areas and work with our partner organizations, and everyone participates in the fellowship together. So we call it site fellows and rotating fellows, and so it's bi-directional and interdisciplinary. We have underserved sites in the US as well as outside of the US, and really focus our curriculum on social justice, and partner with organizations that are grounded in values around health equity, and have had now consistent presence in a number of these sites for years. So knowing that like any 1 to 2 years, change takes a long time. And so the hope is for change over time, and really investing in individuals to change systems over time. And so if you are interested, feel free to reach out to me. But I think it's an awesome program. All right, I think with like a couple minutes to spare, but thank you all for taking the time to listen this morning, and really appreciate all your thoughts and all the work you will do in the future, and are doing now. You guys are all doing awesome stuff, and I think even coming here and starting to think about these issues is so important.
Yeah, I'll echo that. For those that I know on the call, they're doing great work. Very excited to see where their careers will blossom. But thank you so much, Robin, for sharing your work, a little bit about the HEAL Fellowship, and a really important way to think through the patients that are in front of us. So very much appreciative of that. And not just think through it, but to your point also, how to address some of those upstream determinants. We have just maybe a minute or so for questions before we wrap up. Our next session starts promptly at 8:15 on the West Coast. So are there, please feel free for folks to put in your questions in the chat or say them out loud. Would love to hear from you. Fritz, I see you've come off mute.
Yes, just want to thank Robin for this presentation. It's so deep and clear, and how she presents the reality in Haiti. From Haiti, and I know exactly what she has said, and I know that it's not easy, but it's not good to understand and to see what is doing in Haiti with all this population and all the doctors, nurses that are working hard. And I want to thank you. And I see the depth of your presentation, going through all these structural problems we face in Haiti. And I know some of partners in health because I work with them in neonatal resuscitation program, HBB. And I know a lot of them. I worked with them several times. They are doing a good job in Haiti. It's such a kind of partnership we need. And they had so much good things they are doing all over the country. Thank you once more for your presentation. I appreciate it, and I want to thank you for this.
Thank you so much.
Yeah, thank you for those kind words, Fritz, to Robin. And agree. I suppose if it's all right, what I may add is while the presentation was centered in Haiti, it does feel like a lot of the lessons do apply to really every setting and every patient as well. So I think this is a great analysis, both of what's happening in a particular country with those examples and nuances, but also applicable to those who may not be working in that context.
Yeah, if you want to see another example, actually, that's less messy than mine, the structuralcompetency.org, one of their things goes through a Mexican immigrant in San Francisco, and the factors that have affected his health. So again, any context, yeah.
Please go ahead, Fritz. Yeah.
Yes, I just like to know more about your organization. I didn't have the name. I don't know how to reach out to you.
Yeah, I'll just put in the chat a little bit about HEAL. And that website both has an email address as well as a lot more information.
Okay.
All right. Well, thank you again. We have an evaluation in the chat. So if folks can click on that link and take a